Hey, good evening, everyone, and welcome to tonight's webinar on to pee or not to pee, managing bowel and bladder dysfunction with MS. My name is Brian Thompson, and I am Associate Director at Can Do Multiple Sclerosis, and we're so happy that you all can join us this evening. Thank you for taking time to learn more, and we hope that you're feeling well and staying safe out there. For those of you new to Can Do MS, we provide health and wellness education programs and coaching with the goal of helping families live better with MS and to help them thrive. So please visit cando-ms.org to learn more about Can Do MS's programs and resources. And also want to recognize the National MS Society and the MS Society of Canada. They're our partners in our webinar series. The mission of the MS Society is to end MS forever and restore what is lost because of MS. They have tons of really good resources. Their Navigator program is awesome. We'll talk more about that at the end, but nationalmssociety.org. And thank you to the MS Society for their partnership. Thank you so much for joining us here this evening. We hope you find tonight positive and educational. You walk away with some new strategies and some new ideas. We're going to spend a few minutes at the end of the program answering your questions. So a lot of you submitted questions during registration. We'll get to many as those as we can. You can also submit a question if you look on your bar that pops up on GoToWebinar, and you can submit a question under the chat feature. You type, open up question/chat, type in your question, and again, our two speakers will try to answer as many as they can. The GoToWebinar has a support line, so if you're having any technical issues, their phone number is 877-582-7011. So our goals tonight, we have 4 learning objectives. We're going to try to increase our understanding of the causes of bowel and bladder dysfunction. We're going to address individual needs through lifestyle and environment modifications. We're going to initiate appropriate strategies, interventions, and treatment to try to improve your quality of life. And lastly, we're going to try to gain some motivation and learn about some more resources and really walk away from tonight, not just with more information, but some small goals that you can implement today to live a better life. So with that, I'm going to introduce our two speakers. I'm actually going to let them introduce themselves. So first of all, we have Lindie Schreiner, who's a physical therapist assistant from Omaha. So welcome, Lindie. Thanks for being here.
Hi, like Brian said, my name is Lindie. I'm a physical therapist assistant from Omaha, Nebraska, and I work in an MS clinic here in town called Horizon. And I've been here about 6 years and with Can Do for 3, one of those. So I'm so glad to be here and welcome to you all.
All right, and then our second speaker, we always like to have a multidisciplinary team. So along with a physical therapist assistant, we have a nurse whose name is Tracy Walker, and I'm going to welcome Tracy.
Hi, everybody. Thanks for coming. So I am a nurse practitioner. I work at the Shepherd Center in Atlanta, and I have been there longer than I admit. And have been working with Can Do now for several years. And tonight we get to talk about my absolute favorite topic. So I'm excited. All right, so welcome. In case you aren't aware of what we're talking about, we're going to talk about bowel and bladder dysfunction with MS. And I think the biggest thing to know is that you are not alone. This is a huge problem with a lot of people. We're talking 70 to 80% of people with MS have some kind of bowel or bladder dysfunction. So, next slide, Brian. So do not be the little speak no evil, hear no evil patient. Talk to your provider. There's a lot you can do about the problem. And I just want to reassure you, as providers, as specialists with MS, we're used to these questions. We want to know what's going on because we can help, hopefully. So with bowel and bladder dysfunction, symptoms can be constant or they can be intermittent. But regardless of how your symptoms are presenting, there are things that can be done about it. And I think one of the reasons this is one of my favorite topics is that there's a lot you can do outside of medication or treatments or whatever. There are a lot of things you can do yourself. There's a lot of things that therapy can do to help you. And so we're going to talk about all of those tonight. And bowel and bladder of probably all MS symptoms has a huge impact on quality of life. I know patients who won't leave their house because of their bowel and bladder issues. So we want to help change that for you. I think with bowel and bladder, successful treatment really does include lifestyle behaviors, routines, and habits. Then you can seek medical intervention and treatment. And all three of those together are important for success. So I always start with, how does a normal bladder work? Before we talk about how MS can affect the bladder and mess it up, let's talk about how it normally works. So a normal bladder fills with fluid, and then as it reaches a normal capacity, it starts to spasm and alert your brain. So it sends a signal up the spinal cord to the brain and says, hey, I need to empty. And your brain says, no, wait, we got to get to the appropriate place and get ready to do this. I'm in a meeting, you got to wait for me to get to the bathroom. So then you go to the appropriate place. It may be half an hour later before you're ready to empty. So you get there and your brain says, okay, guys, we're ready, go. And that message goes back down your spinal cord to your bladder and the nerves and muscles around that. And what happens, or what is supposed to happen, is the sphincter muscles relax and the bladder muscles contract and the bladder empties completely. So that's your normal bladder, okay? So what does MS do to that? Well, there's a lot of things it can do. It can cause a bladder to empty too often, okay? It empties completely, but it empties too frequently. We refer to that a lot of times as urgency frequency, okay? Or irritable bladder is another way people describe that. It can cause a bladder to empty partially or not completely. So it may not empty often, but when you do empty, it's still carrying urine around. And so we refer to that a lot of times as urinary retention. Sometimes those sphincters don't relax and open like they should, and that's what dyssynergia refers to, okay? One of the key things to know is that both of those can cause incontinence. Some people don't realize that both of those conditions can cause leakage of urine. Okay, so let's start with your bladder that doesn't hold much, okay? What would you experience? Obviously, frequency. You're going to be going to the bathroom more frequently than you think you should have to, or than a normal bladder makes you. You may have that really strong urge where it's like, okay, I can't wait. I've got to get up right now and get somewhere as quickly as I can. And a lot of times you have leakage before you get there because of the urge being so strong. They call that urge incontinence, or they refer to it a lot of times as keyhole incontinence, because people will have that urge and they're trying to get in their house and their bladder will empty right as they're opening the door. It also can cause a lot of loss of sleep, because people will tell me sometimes they get up 5 and 6 times a night to empty their bladder. I love this cartoon. Urology department, can you hold? Okay, so what can you do about a bladder that won't hold urine or hold enough urine? There are medications that you can use to calm the bladder and the nerves around the bladder so that it doesn't spasm so frequently, so the urge is not so intense, and a lot of times people will not have as much leakage on those medicines. Now the problem is those medications have side effects, particularly side effects that affect the bowel. And there's a reason why we're talking about bowel and bladder together, because often, usually, people have somewhat of both problems. And so these medications often are drying, so people can have more constipation on these medicines. But many of them can be very helpful. Pelvic floor muscle therapy is great, and Lindie's going to talk a lot about that. I'm a big fan of pelvic floor muscle therapy, and way back in the day used to do that, so I know that it works. Another therapy that was somewhat recently approved is Botox treatment for the bladder. What happens is they inject Botox into the bladder muscle to relax it. And then it's effective for several months. It's not permanent. So people have to go back and, have the treatment again. It, time frame varies for folks. The problem with Botox is it paralyzes muscles. So they have to be very careful not to do too much Botox because sometimes people can't empty their bladder afterwards. So that's a possibility. They always teach people how to catheterize in case they're temporarily unable to empty. There is another treatment that is not on this slide that has, I've heard more and more patients pursue, and it's called percutaneous tibial nerve stimulation. And it's sort of like it's not acupuncture per se, but it's kind of like that. But basically, you go and you have usually about 12 treatments, and it's a neuromodulation kind of treatment, and gradually, supposedly, it helps the frequency in irritable bladder. So I've seen a couple of patients who've had this done, and they both had good results. It does say that sometimes people will have to come back and get tune-up for that as well. So a lot of people call it PTNS for short. So those are all things you can do. And then Lindie's going to talk about some other lifestyle types of things that really help that urgency frequency. So what can you do if your bladder does not empty well? Okay. First of all, many times the first clue that somebody's bladder isn't emptying is they start having urinary tract infections. And a lot of times I'll ask patients, hey, are you emptying your bladder completely? And they're also having that urge and that frequency. And so they're like, oh, absolutely. I go so many times during the day, it's got to be emptying completely. But what they don't realize is their bladder is holding on to so much urine because they're not ever emptying it completely, that's what's causing them to have to go so frequently. So many times they're not aware of it until they start having infections. And the bladder, when it stays over distended for long periods of time, it can't fight off infection as well. So usually that is a primary cause for urinary tract infections, especially repeated urinary tract infections. So you may also have hesitancy. So what is hesitancy? Hesitancy is when you go to the restroom and you have trouble starting your stream of urine or, going period. So there are tricks you can do for that, turning on water, flushing the toilet, things like that. Distracting yourself sometimes can help. So a lot of times folks will have, again, urgency urgency, just like frequency and urgency, but usually that urgency is because they're carrying around so much urine. Okay. Next one, Brian. So what can you do about that? Well, you know, the first thing people do is they stop drinking. And it's important to maintain adequate fluid intake because a moderately full bladder is usually easier to empty. And restricting fluids, Lindie's going to talk about how bad that is for the frequency and irritability of the bladder, not to mention bowel issues and other just general hydration. But a lot of times we have people go empty their bladder on the clock. So they have a structured time voiding where they don't wait for an urge. They go every 2 hours and, you know, do what they can to urinate and use some of those tricks that we talked about to get their bladder to empty. There are medications. We talked about the sphincter muscles sometimes don't open. They won't relax. And a lot of times if people have a lot of muscle spasticity, this is a problem for them. But there are medications that will help relax the sphincter. So sometimes that will help them empty more completely. And then finally, sometimes people need to do some catheterization. Intermittent catheterization, I feel like, has gotten a really bad rap. Nobody comes and says, "Oh, I want to do that intermittent catheterization. Show me how to do that," you know. But I will say so many patients who have avoided it for so long ultimately feel so much better once they start doing catheterization and stop having these urinary tract infections that they wish they had done it sooner. So next slide, Brian. So people ask me all the time with retention, you know, if I can live with this, then why should I bother doing catheterizations or anything for that matter? I'm doing okay, you know. And the first thing is urinary tract infections obviously not only cause symptoms, fever, all those things, but they also increase MS symptoms. Those pseudo relapses many times are from urinary tract infections. Also, urinary tract infections can be life-threatening. You know, people have to go to the hospital, get IV antibiotics. If the infection gets in their bloodstream, it can be deadly. So it can be a serious issue. Also, over time, if your bladder is constantly full, it can cause high pressure that backs up to your kidneys, okay? Over long periods of time, with this happening, it damages the kidneys. And then that leads to kidney failure and dialysis. So if you aren't emptying your bladder and you're really carrying around that much urine, please see your provider and talk about what you can do, okay? So you go see your provider. What are some things that they may do? Well, first of all, many times people come in with a mishmash of symptoms, right? They have some symptoms of urgency, frequency, but then they may not be emptying completely. They're not sure. So the first thing we do in our clinic is measure how much urine is in the bladder after somebody urinates. And we call that a post-void residual, okay? So we have folks go to the bathroom, empty their bladder as completely as they can, come back to the exam room, and there's a little ultrasound machine with a little wand, and we have you lay down on the stretcher, you know, just pull down the pants slightly to get to the lower abdomen, put some jelly on it, and scan your abdomen, and it tells us how much is left in your bladder. Now, obviously, if that can be done more than once, it's helpful to see what the trend is. But if there's a lot in there, then you're probably going to get referred to urology or, you know, some other type of testing to see what needs to be done to help you empty that bladder better. If you're not carrying around a lot of urine, then you might, if you're having urgency frequency, they may prescribe one of those medicines to calm your bladder. But they need to make sure you're not holding on to urine first, because if you think about it, to empty the bladder, there we go, it has to squeeze. And so if you relax it too much, then you don't get a full emptying. So those medications can lead to you retaining urine. So we need to make sure before we prescribe those medicines that you're emptying completely. So they may talk about lifestyle issues. They may refer you to therapy, which is great. Then they may want to do further testing. So those are all things that your provider may offer you.
Okay.
All right, take it away.
Thank you, Miss Tracy. So this is an overview list of some things that you have control over, things that you can actively do to make positive changes with your bowel and bladder changes. A lot of these go hand in hand with bladder and bowel because these issues do typically go hand in hand. Water intake, our diet, exercise, pelvic floor rehab, physical therapy. I suggest starting with physical therapy if you're new to exercise, so we can kind of help pick and choose the best exercises for each individual, because it's not going to be the same for everyone. And then creating efficient spaces in our bedrooms and bathrooms. So I want to touch on, go ahead and go to the next slide. Thanks, Brian. Water, we need 48 to 64 ounces per day. No, pot doesn't count. Don't talk to me about drinks with caffeine and sugar, all that business. Don't even talk about it. We're looking for straight water. It's important to consider slowly increasing your intake of water too, so we don't overwhelm the bladder. You know, if it's not used to 48 ounces a day, it's only going to maybe contribute to more leakage or incontinence issues. So we want to be very careful about that. Our diet, avoiding bladder irritants. We'll talk about those on the next slide, but just cutting some things out, changing some things can truly have an impact on incontinence as well. Exercise, get your body moving. General strengthening and cardio can help strengthen the pelvic floor without even directly focusing on it, because a lot of times if we're straining or using our core muscles, we actually kind of recruit the pelvic floor as well without even thinking about it. And creating efficient spaces in our bedroom and bathrooms is important, because we want to create a direct path clear of any kind of obstacles. So removing all the tchotchkes, which are those unnecessary decorations or pieces of furniture that are prohibiting you from getting in and out of the bathroom safely, quickly, efficiently. So we're talking about moving throw rugs. We don't want any trip hazards, anything for assistive devices to get caught on, anything for you to trip on in the dark. You'll notice here that I've got photos on the right-hand side. One of them is a nightlight. I strongly recommend this for nighttime bathroom trips. And then also, if you're just trying to be a kind significant other and not turn on the light while your significant other is sleeping, I recommend that. Also, a few grab bars next to the toilet just for easy on and off access. And then this first top left photo, you'll notice is a squatty potty. We'll touch on that in a little bit. Okay, Brian, thank you. So these are common bladder irritants. Okay, so this is something that we can change by our diet. So removing caffeine, alcohol, aspartame, and smoking also irritates the bladder. So those types of changes we can make. Concentrated urine is a big topic, and it's listed first because it's very common with folks that have bladder challenges. We're afraid to drink too much if we have a leaky bladder, and so we don't drink too much. And then the urine that's in our bladder that's sitting there for long periods of time is highly concentrated. And what that's doing is irritating the lining of the bladder, which can then lead to an infection, UTI, bladder infection, even work its way up to the kidneys. And that is something we definitely want to avoid. Okay, perhaps timed voiding would be a technique to try for some of you. The goal of timed voiding is to decrease urgency and incontinence. So what you do is you take a diary, you write down how many times you void during the day, and you write down when you do that for a few days. And then what you do is you try to go to the bathroom 15, 30 minutes before that. So you're going to collect a bunch of information and then try to beat it to the punch, essentially. So you can do it that way, or like Tracy mentioned earlier, just trying to empty your bladder on a regular schedule, like every 2 hours. So either figure out your exact schedule, which would be very highly individualized for each person, or just go ahead and start the 2-hour rule. If you're having troubles voiding every 2 minutes, like I really don't have to go, or 15 minutes beforehand, I really don't have to go yet, just sit there, be patient. You can stimulate your own reflexes either by like tapping your fingers over top of your bladder, which is right above your pubic bone. You can run water, that sometimes helps. Tracy mentioned flushing the toilet, or even sticking your hand under warm water can certainly help start that flow of urine. Double voiding is another technique, and that is for when we want to empty the bladder more completely. So what we do is go to the bathroom, void, go ahead and either get up or walk away, do something else in the bathroom, like we suggest wiping the counter, maybe fold some towels, whatever, and then come back and try again. And you can repeat that a few times just to make sure that we're getting your bladder more empty. And then also, quick access to the bathroom, it goes back to creating efficient spaces, making sure we have a clear path, avoiding all unnecessary obstacles. I mean, because typically when it's time to go to the bathroom, it's time to go to the bathroom. We don't want to mess with anything else. And then lastly, pads or protective undergarments can be used as needed. Most folks will utilize them when they're leaving the home if they feel like they just need an extra layer of protection, especially if they're going somewhere where the lay of the land is unfamiliar. So we recommend those products for folks that have leaky bladders. Okay, so can physical therapy or even occupational therapy help? The answer is yes. A lot of folks don't know that this is an option. They're unaware that there's even pelvic floor rehab. A PT or an OT certified in pelvic floor rehab can help sort through your symptoms and help create an exercise program appropriate for each individual. You can expect an evaluation at your first visit where you'll chat about your concerns and your goals, and then the therapist will more than likely hook you up to biofeedback to measure the strength of your pelvic floor. Biofeedback is a tool we use for rehabilitation, and what it's used for is to measure, like I said, the strength of your pelvic floor. So it's that part that supports the lower part of your trunk, and we'll get into the anatomy in just a little bit. Dr. Mark Schwartz, who is a guru of biofeedback at the Mayo Clinic, indicates that, well, basically defines biofeedback as a training technique that enables an individual to gain some element of voluntary control over muscular or autonomic nervous system functions while using a device that produces auditory or visual stimuli. Now, the one that I'm mostly familiar with is a visual contraction. It shows you exactly how hard you're squeezing or contracting that pelvic floor, and we'll go over that in just a second. But it can be used for both strengthening, we call that up training, if we need to strengthen the pelvic floor, or if muscles are spastic and too tight or shortened, we'll call that down training, but it is beneficial in both cases. Core strengthening and pelvis and hip strengthening are also important. They can lead to a positive change because, like I said before, what's happening is you're not even realizing you're using your deeper core muscles You're not realizing that you're engaging your pelvic floor a lot of the time when we're doing those big motions like moving from the sitting to standing position in order to get to the bathroom. When we're using those big muscles, we're still recruiting the smaller ones that we're unaware of. Kegels, everybody's heard about Kegels. If you can go back, thanks, Brian. We'll touch on those in the bowel as well. Because of the anatomy, we see exactly where the pelvic floor is. It's going to benefit both areas, bladder and bowel. Typically, we'll start in a gravity eliminated position. So typically we're starting laying down, and we don't have to work against gravity. We're just working against ourselves, trying to engage that muscle, trying to figure out exactly how it works. If maybe it's like, how do I make that contract? Well, I'm guessing most of you are trying right now without even thinking about it, but essentially it is contracting the muscle to stop the flow of urine. So if you think about going to the bathroom and you're like, oh, I'm going to stop, and you stop, that's that muscle contraction. That's your pelvic floor of not allowing that urine to flow anymore. So that's the muscle that we're trying to get at. Go ahead and flip to the next slide, please. So this is what it might look like if you are on biofeedback with a therapist. The first photo I have on the left is probably the beginning stages. You can't probably see very well the contraction, but it's kind of working up into a peak, and then it slowly relaxes, works up into a peak and slowly relaxes. So your therapist will cue you to contract your pelvic floor, and then you can watch how hard you're contracting. Now, in the second photo here, you'll see that there is a gal she's bridging, she's got a ball squeeze going on. So we try to hold those pelvic floor contractions while we do other things. Bridging, we'll move to the sitting position, we'll move to the standing position, and just start to work against gravity in addition to doing other tasks. So there's quite a bit of positional changes once you start to meet your goals and that pelvic floor contraction gets stronger. We start to move you into different positions in order to complete those contractions and make it more challenging. Go ahead. Yes, so the pelvic floor, where is it exactly? You'll see here the tailbone, which is the coccyx, on the bottom part of the spine, and there is a red sling-like, which essentially that's what the pelvic floor is, attaching to your pubic bone, and that's what kind of supports all your intestines, your bladder. It supports everything. It's holding everything in. So when you have a weak pelvic floor, that's when we notice those challenges with the bladder. We notice the challenges with bowel, and just sometimes even discomfort and pain and all of, I mean, it's a whole mixed bag of symptoms that you can experience with a weak pelvic floor. So where does the biofeedback go? Or what is that like? So if you have two electrodes, imagine two electrodes near the coccyx, two electrodes near the front of the pubic bone. And what we're doing is measuring that contraction with electrodes that transfer onto a screen to show you how hard you're contracting your muscles. In addition, some therapists have access to an internal biofeedback. So that would just be inserted typically mostly into a female and measuring it that way. And then electrodes are typically used for a male. And I like this cartoon. Grinch's small bladder grew 3 sizes that day.
All right, on to poop. I tried hard to find my last Halloween picture. I was the queen of poop. I had the poop emoji and a crown. I had the little bladder on my wand, but I couldn't find the picture. But anyway, all right. So what's our goal with bowel management? Obviously, we want to have a comfortable bowel movement in an appropriate place. Okay, obviously. So how do we do that? Lifestyle behaviors are really important, especially with bowel. So Lindie's going to talk a lot about these. But one of the things I always include in my talks is that the good news is your bowels are creatures of habit. So if you do the same thing and you establish those habits and routines, you can train your bowels to do what you want them to do most of the time. The bad news is your bowels are creatures of habit. So you have to do the same thing all the time. You have to be consistent. So that's an important part of bowel management. Next one, Brian, thank you. So normal bowel function. Okay, once again, let's talk about how a normal bowel empties, and then we're going to talk about how MS can affect it. So the bowel is a little bit different from the bladder, but also very similar. But there are a lot of things that can independently affect bowel function. And we're going to talk about all those. But normally, you eat food, it goes down into your stomach does what it does to help digest it, then it goes into the intestine. So when it starts in the small intestine, moves through the large intestine, it's moved through by what we call peristalsis. And peristalsis is something that your body normally does. It's not something you do, but there are things that you do that help improve peristalsis. And one of those things is just moving around. So we'll talk about that a lot. But bowel motility is what we refer to when we're talking about peristalsis, that movement of fecal matter through your intestines. So it moves through your intestines and it ends up in the rectal vault. Okay, the rectal vault I think of as kind of like the bladder. And so when the fecal matter ends up in the rectal vault, there are stretching sensors there, and so the rectal vault recognizes that there's stool there, and it sends that message to the brain that, hey, there's stool here, I need to go empty, and your brain says, not yet, hold on, I got to get through this seminar on bowel and bladder, then we'll go to the bathroom. So the brain says, don't do it yet. And so then later, hopefully whenever you're ready, you go to the restroom and the bladder says, okay, we're ready. Same thing happens. Your sphincter, which includes the pelvic floor muscle, that relaxes. And you have some increased abdominal pressure, and the muscles help evacuate the stool. Okay, so how can MS affect that? So first of all, there are two main problems with MS and bowel problems. First of all is constipation. That's the most common. Now, I've talked to patients and said, are you constipated? And they say no. And then I ask, well, how many times do you empty your bowels? Oh, well, maybe 1 or 2 times a week. Okay. Constipation is 2 or less bowel movements a week. What's your stool consistency? That's always a great question. The first time I ask that question, everybody's eyes kind of get big. But yes, what's your stool consistency? If your stool is too hard and too dry and little pebbles, that's constipation. Okay? Because also it hurts. So going back to that comfortable bowel movement, okay? If you have to use laxatives or a lot of medications to make your bowels move, then that's considered constipation. The other way MS can affect the bowels is fecal incontinence, involuntary loss of bowel control. So that's less common, but obviously of great concern when that happens to people. So, next slide. So let's talk about constipation first. Okay, we talked about some of the symptoms with constipation, but some that people don't recognize. Obviously, if you have a lot of gas, that can be related to constipation. Some people can feel that bloating and fullness in their abdomen. Some people can actually feel a mass of stool in their abdomen. Also, people complain of headaches. It can cause headaches, It can cause a decrease in appetite. If it's really bad, it can make people nauseated and vomit. It can really increase fatigue. So what you need to realize is that your bowels eliminate a lot of toxins from the body. And so if your bowels aren't working properly, a lot of times that can really slow things down and fatigue the body. One thing that I always ask folks is, okay, if they complain of diarrhea, the first question I ask is, well, were you constipated a few days ago? Because diarrhea can occur when you have a really severe fecal impaction, and we'll talk a little bit more with that on the next slide. Next, Brian. Okay, so causes and contributing factors to constipation. Well, when you have impaired mobility or you're not as active, that decreases some of your bowel motility. So those muscles, the abdominal muscles and all the muscles surrounding your bowels aren't helping move that stool through. MS can have a direct effect on bowel motility. People can have a slowed bowel motility from the effects of the MS. Also, sometimes people don't have the sensation or don't get the signal from the sensation of that full rectal vault. So they don't know that they need to empty. So they're missing that signal. Some people don't have the strength in their abdominal muscles to help them empty completely. So they get maybe more frequent bowel movements, but not thorough emptying of their bowels. Some people either are dehydrated or they don't have that fiber or those things in their nutrition to help their bowels move. Medications, some of which we use for MS, can really contribute to constipation. We talked about some of the bladder medicines. Pain medicines can cause a lot of problems with bowel, and there are others, lots of others, that can contribute to constipation. So,
oh man, this one gets me.
Yeah, I always say if you've been constipated, you can relate to that slide. Okay, it's very uncomfortable. So, all right. So what do you do if you are suffering from constipation? So first of all, we use those lifestyle measures because a lot of times we can really impact constipation and minimize it with the lifestyle measures that Lindie's going to talk about. Then I usually, if people have really firm stool and we maximize their fluid, use appropriate fiber sources, then we may add stool softeners, okay? What you need to know is on bowel treatment regimens, there's kind of a scale of bowel medications. There are those at the bottom of the scale that have very few side effects, are okay to use. Then as you move up the scale, you have things that are harder on the system that you should only use those items at the top of the scale if you absolutely have to, right? So we want to always use the lower end of the scale as much as possible. So stool softeners are on the bottom of that scale there. You can use those if that helps your stool becomes softer and easier to empty. Then I usually have people add something to that regimen if they've not had a bowel movement in 48 to 72 hours. Now, first of all, I have people always visit the restroom after 20 to 30 minutes after they eat. And, I also say if you sit, it will come. And that's not always true, but a lot of times it is. So always have that routine of visiting the restroom when you have that routine set up. So, but if you have not had a bowel movement 48 to 72 hours, then we add the next level. And the next level is usually a bulk or osmotic laxative like Miralax or a suppository. Suppositories are great because they just affect the lower part of the bowel, so it's not a systemic effect. Then if we have to, we move up to stimulant laxatives. You want to try to stay away from those, and also they tend to be more uncomfortable for people if they use them, and the results are a little bit more unpredictable. So that's how we usually do it.
Okay.
So, Lindie?
Yes, ma'am. So here are a few tips for some bowel challenges that a lot of folks are experiencing. Diet is huge. If we are increasing our fiber, that's helping things get pushed through. It's also important to remember to essentially eat at the same time every day so that you can get on a bowel schedule about the same time every day. So if you are timing your meals, what's happening is physiologically you're eating, it hits your stomach, and then once your body feels your stomach stretch, we have the gastrocolic reflex, which is essentially the colon is starting to push things through, empty the contents, and then about 20 to 30 minutes later, voila, you should be able to void. So getting on a good fiber program and then getting on a good mealtime program can help you time your bowel movements, and also increasing, we've talked a lot about this, increasing your water to help the stool stay a little softer. It's complicated with medications that you're taking and how they can change the consistency of your stool. However, if you're increasing your water take, increasing your fiber take, getting on a daily regime of I'm going to eat at this time, this time, this time, so I know 20 minutes, 30 minutes later, I should visit the restroom and just try and go ahead and be patient. It doesn't always happen right away, but if you try, you should have a good result. And then also bringing in the squatty potty. This is my last bullet on this slide, is the game changer. Changing your position can certainly help. If you are opening up your colon so that there's less restriction, creating a path of least resistance, you'll have an easier time voiding your bowels as well. Another tip to try, you can go ahead and go back, sorry, Brian. Another, back one. Thank you. Another tip to try would be a bowel massage, which we'll try on a hands-on technique in a bit. And then exercise is also very, very important. Go ahead and flip to that next slide, Brian, pretty please. Okay, so this is a photo of what your pelvis looks like when you're regular sitting on a toilet versus what it looks like when you've changed the angle of your hip. Your knees are now above your hips and you're opening up that colon to allow for better flow when you're trying to void your bowels. So bringing your knees up, changing that position can certainly decrease the strain, decrease the amount of time that you're sitting there, and just make it overall more enjoyable experience. So if you haven't tried it, give it a whirl. Okay, so I want to review the bowel massage, and you can do this. You can do it on yourself. It's easy, hands-on. If you have someone that loves you and they want to do that for you, you can certainly do that too. But let's look at the anatomy first. So if you look here, the esophagus is faded out, the stomach is faded out, and then we go into the small intestine, that's faded out as well. So where we are focusing our bowel massage is across the large intestines. Okay, so if we look, we'll see the ascending colon happening from, this is an anatomical position. So the ascending colon is from the right pelvis to the right ribs. The transverse colon is from the right ribs to the left ribs. And then the descending colon is from the left ribs to the left pelvis. So on each one of you, you're going to palpate. So you're going to feel the bottom parts of your ribs, the lowest part of your ribs that you can feel. And then you're also going to take note and feel those bony parts of your hips. Okay, those hip hip bones that just stick out, okay? So between those, that's where all the magic is going to happen. So where we're going to start first is the descending colon. We're starting from the left rib to the left pelvis. And I'm going to use the heel of my hand. And what you do is you just kind of push into your stomach a little bit. You push into the tissue, not too deep. But what you want to do is just kind of almost grab and move tissue. I'm sorry that you can't see what I'm doing here, but move the tissue downward. And we're going to do that 10 times. Okay, so just kind of moving the left rib to the left pelvis with the heel of your hand, like so. So 10 times on that. And then the transverse colon, we're going from right rib to left rib. I'm going to use my fingers here, still pressing in. You want to indent a little bit, but not too far. And pulling across to your left rib. So right rib to left rib. You're going to do that 10 times. Okay. And then we're going to go to the ascending colon, right pelvis to the right rib. I'm going to use my fingertips again, switching hands. And you're going to pull upwards from the right pelvis to the right hip rib 10 times. Okay, so that is an easy peasy hands-on trick that you can do. It should not be painful at all. You're just kind of gently pressing in and trying to move the tissue in the direction indicated depending on the colon that you're working on. If you flip to the next slide, Brian. Firm pressure, but not too deep, and then recommendation of 1 time a day, usually at night, but fit it in when it works for you. So I want to reiterate, this should be done in the laying down position. So when you're going to bed, you might as well just do it then. Just kind of help things move through, and then you'll start your next day. So here is a few examples of some exercises that someone would do with bowel and bladder issues, to be quite honest with you. So we talked about the the Kegels and the progressions. And then we'd also add in some big muscle groups, some sit to stand muscles while we're still doing the Kegels as well. So you would always constantly think about engaging your pelvic floor while we're doing these other types of exercises. So inner and outer thigh squeezes, if you think about laying on your back and doing those butterflies with your knees bent, your knees go out, still contract your pelvic floor. You want to put a ball between your knees and squeeze in, still contracting your pelvic floor. So we start small, we start gravity eliminated like we talked about earlier with those exercises, master them, and then we start to sprinkle in these bigger muscle groups where we're still having to recruit the pelvic floor. Ab exercises are going to be good. They help things move. They help things move through the intestines. Just kind of getting natural muscle contraction can help move things through the colon. And then, of course, cardio. Cardio is huge. Walking, biking, swimming, any of those are going to really get have a powerful impact on your bowel schedule and your bladder schedule. So meeting with a physical therapist can certainly help you pick through what's going to be the best for you, because like I said earlier, it's going to be very different for everyone. Not everyone has the same challenges, and we can certainly help figure out the best route for you. So finding a PT who knows MS is going to be top notch for you.
Awesome, thanks. So, okay, moving on to fecal incontinence. There can be a lot of different causes for this. We talked a little bit about impaction. And if you've had a really bad constipation and all of a sudden you start having a lot of watery diarrhea, then you may have a blockage. So if that's the case, a lot of times you may have pain, you may feel nauseated, but if you suspect that that's even a possibility, you want to get it checked out, because it can lead to bowel perforation and infection and serious problems. So, but if it's not impaction or constipation, then sometimes fecal incontinence can be due to that rectal sensation. And also sometimes people's sphincters are weak, and so they can't close off and hold in stools. very well. And so if their stool is soft at all or liquid at all, it will leak out. Sometimes people have dietary issues that can contribute, and obviously medications of different kinds can contribute as well. Many times people have been on antibiotics a lot for UTIs, and then they start having diarrhea from that. So, next slide. So what's the treatment? How do you work with that? So first of all, I usually have people, especially if it's a recurrent issue, go ahead and see a GI physician and have a full medical evaluation to rule out all those other causes. A lot of times people may have irritable bowel, and it may be in part related to MS, it may be totally different. There you can have infections. C. diff is something that has made its way around a lot of folks, and sometimes they don't recognize that initially. And so be sure that you always rule out infection or have a evaluation to rule out infection. Different foods can cause intolerances, which can increase diarrhea or loss of control of the bowels. Lactose is a common issue. Gluten intolerance can be an issue. Sometimes it's greasy food, spicy food. So I have people, when they have a lot of incontinence, to think back to what their last 2 or 3 meals were. Usually it's the last one, but not always. So a food diary along with your bowel history can be helpful to isolate any issues that might be contributing. And so then we actually, Brian, sorry. Then we actually have you we rule out all those things. Then the first thing we do is the same thing we do with constipation, is put you on a regular bowel program. Okay, we try to get the right consistency of stool, manage that, not too soft, not too firm, and then we have you do the same thing. Go sit on the potty same time every day. Use something to help you empty completely, so that you don't end up having a full bowel when you're out doing something and it's not the time you want to have an issue. Now, some people use fiber loading, and that's when you actually, if you're having a lot of loose stool, you actually take a lot of a fiber supplement or a high fiber food. One thing to know is soluble fiber. There's soluble and insoluble fiber. And soluble fiber is really the best for fiber loading. Just be patient. It takes a while to establish good bowel habits. The next slide, Brian, quickly, is about soluble versus insoluble. So both types of fiber can help constipation, but soluble fiber helps mix with the fluid in your bowels to slow. It makes a gel that kind of slows the movement of the fecal substance through the intestines. So it helps kind of slow things down. Things like brown rice, dark green vegetables, wheat bran, celery, those things are soluble fiber. Insoluble fiber is the best for bulking up the stool and helping constipation. One last thing to say about fiber is never, never, never use fiber without adequate fluid. It's concrete. So if you're not drinking your fluid one day because you're traveling and you don't want to be stopping all the time, don't take your fiber or don't eat a lot of fiber, because it will constipate you. Those two things have to go together. And I think resources.
So what this is, just a few resources for you to look into for some of the adaptive equipment like that was posted within the presentation. So the squatty potties on there, night lights, grab bars, all of that's available on Amazon.com. education resources for you, National Association for Continence, and then the National MS Society. Their websites are listed there for further review of their articles and information there. And then supplies, should you need some, home delivery incontinence supplies, and their web address there. So just some places for you to visit should you need to. Mm-hmm.
That is actually my 14-year-old son, who does not know that his picture is on the end of our presentation. So, but
every presentation.
That was during potty training. Yeah.
All right. Well, thank you very much, Lindie and Tracy, for all that great information. We hope that was informative for folks to understand why things are going on and what you can do to take steps to improve it, and who you can ask, most importantly, who you can ask for help. So hopefully that gets you on the right path a little bit. We've got some questions that came in. As people are submitting questions into the chat box, just a reminder that we will be sending you a survey out in about 15 minutes. So if you could take a few seconds just to let us know what was helpful in this webinar tonight, what we could do differently next time. All the feedback that we can get makes our programs even better. Also, we know that's a lot of information, so this will be archived on the CanDo MS website and on our YouTube channel. You'll also get a PDF copy of the slides. If you click handouts, there's a way to download it there, but we'll also email all of them to you tomorrow. So with that, we do have a few questions. We'll start with Tracy. We have one person that was told by their doctor not to push hard when they're making a bowel movement. Can you explain why it's important not to push hard?
Yes. So a lot of times, especially when you have weak pelvic floor muscles and lack of support, and Lindie, you can jump in here and help me with this, but when you strain, you can actually cause hemorrhoids. You can cause some of the different organs to be prolapsed. So you never want to strain hard. Now, some ways you can increase your abdominal pressure without straining so hard is you can put your arms over your lower abdomen and just kind of rock back and forth. Lindie talked about raising your knees and getting in that squatty potty position. Lindie, what else would you recommend?
Honestly, another thing is just eliminating the Valsalva maneuver, which is holding your breath. Don't hold your breath. Make sure you have good airflow when you do go to push. And like Tracy said, putting your arms across your lower abdomen, leaning forward into it because you're increasing your hip angle at that point. And just make sure that you're breathing out at the same time that you're pushing. You never, never want to hold your breath. Then we run into the issues with the prolapsing and the hemorrhoids.
So the one thing, Brian, I would add to that is if you find that you have to strain to evacuate your bowel, my answer to that would be, first of all, you need to manage your bowel consistency. Make sure you're using that fluid and fiber to make it as bulky and semi-soft as possible, easy to get out. And then if it's not coming out naturally, then that's a person that would be a great candidate for a suppository, because the suppository can stimulate your rectal vault to contract and empty better for you, so you don't have to strain.
That's a great points. Thank you both. And thank you, everyone, continuing to submit questions. Hopefully you found that questions box, and you can keep sending them in. And we also have questions that people submitted during registration. And talking about routines, we talked a lot about that this evening. But that can be really hard to make that a habit and make it regular. So what would you recommend just as a good place to start to really turning actions into routine?
Well, I can take this one. I think that doing a diary of voiding schedules, but then also keeping a diary of your eating schedule. 30 days of doing that will turn into a habit. It'll just become natural that that's going to be, I know I'm going to wake up, I'm going to have breakfast at 7:30, 8 o'clock. I'm going to take a minute and try. And then the same thing happens at lunch and the same thing happens at dinner. So it takes an effort in the beginning to be diligent with it, but once you get into the routine and it's stuck, it should be easy peasy from there out. So I think just starting to journal, figuring out what's going to work best for your schedule. If you're working around work, if you're not working around work, what's going to be best for each individual is going to be probably the biggest barrier of the starting the whole process of figuring out what's going to be best. So just start diarying, start writing it down, keeping track, and then go from there.
Great. Anything else to add, Tracy?
Yeah, I would, you know, a lot of times people are already using tools that they don't realize. So there are things that stimulate bowels, and coffee is a famous one, you know. Doesn't work for everybody, but a lot of people know. They're morning people because they have their cup of coffee, they have their breakfast, and then they visit the restroom. So if that's been something that's helped you in the past, then you can set up your routine around that morning time when you have your coffee and you know you're going to go sit for a while. One funny story, when I was potty training my son, I realized that there's a big difference in how women have their potty times and men have their potty times. I was trying to train him like a woman, and I would get frustrated when he would be in there 20 minutes and not have a bowel. And I realized that he needed a little more time. So I started leaving him to it for longer periods of time with a book, a little car, or whatever. And lo and behold, we started having bowel movements. So sometimes we try to rush things. So take a magazine, lock the door so it's quiet, and make it kind of your time, right?
Whatever works. That's great. Thank you for sharing that. You mentioned coffee, but to go back to beverages in general, 2 follow-up questions on the drinking of the water. Is there a time limit that you would recommend, you know, after this time at night, maybe not a good idea to start drinking more water? And then with water, can it be carbonated? Can it be flavored? Does that make a difference?
So yes and no. I do think limiting your fluids about 2 hours before bedtime is helpful for most people. I do think, you know, plain old water is the gold standard, so to speak. I'm one of those people that's hard for me to drink plain water. So I have to flavor it a little bit or have a little something extra with it. So in terms of hydration, any fluid that's not concentrated, caffeinated like espresso, or something that is really an agent that causes diuresis, it counts. It just doesn't count as good. And so carbonation sometimes, you know, Lindie talked about caffeinated beverages and coffee and tea and sweeteners. Those all can irritate the bladder. So it is best to try and, at least if you're going to drink those, dilute them as much as possible with fluid. Now, I will say timing your fluids, drinking all at once or sipping throughout the day, I actually have a little bit different view. I think that's very individual. I think some of our bladders can handle loading up our fluid at meal times, and we go and empty and we're good to go for a while. Other of us have those little bladders that we have to sip to get our fluids in, and we just have to go more often. So it depends on you and what your normal is.
We also got a couple questions about incontinence, so overflow incontinence and urinary urge incontinence. Has there been any other practices besides, what we talked about that's been successful with people in MS?
I think we covered most of them. I would definitely use the positioning techniques and the double voiding techniques for folks that don't empty their bladder completely. A lot of people tell me I think I've emptied completely, and then I stand up and I realize I have to go back again. And like Lindie said, that double voiding, I tell people just to stand up, wipe, stand up, count to 5, sit back down. Sometimes it takes a little longer, it just depends. But using those techniques to, really empty your bladder completely can help. And then eliminating those bladder irritants. Do you have anything to add to that, Lindie, that I missed?
No, I think the double voiding would be the big take-home piece for those folks with that question.
Great, thank you. Let's see here. I think we have time for a few more questions, and we still have some coming in. Want to talk a little bit about catheterization. We talked a little bit about that. Can you talk about urinary retention and how catheterization might help with that? And are there any concerns like kidney damage that people should consider when thinking about that?
Yeah, so actually, we talked about some of that in terms of why it's important to empty your bladder, however you're emptying. And a lot of times people may not have discomfort, and maybe some people may not have really bad urinary tract infections, but it's still important to empty your bladder, and because of the potential for kidney damage over time. The other thing is, I think a lot of times when people think of a catheter, they think of huge, big, catheters that they see on TV or whatever. And a female catheter, they have them now that look like little lipsticks, and you push a button and the catheter is like this long, and it's very discreet. Women can be taught to catheterize in public restrooms using sensation or mirrors or different tools that I'm sure Lindie really is an expert on. But I think the biggest thing is don't be afraid of trying catheterization. And a lot of people think they can't, and they find out that they can. And I've seen tremendous benefit from folks just catheterizing once a day. If they can empty some the rest of the day, then getting that extra out at bedtime can help prevent a lot of the infections and stuff. Now, that may not be an option for everybody, but I think, having that conversation and being open to it is important, because you may be surprised at how much better you feel. And what an improvement it is if you are able to do that. Lindie, you want to talk about tools or techniques or ways to help? Anything you have to add?
To be honest, I'm not well versed in catheterization. And as far as tips and tricks, I think the gadgets that you're referring to I really can't speak into detail on those. But the mirrors, yes, compact mirrors, just to help find the right place. And then also people will just carry the stuff that they need in their purses. And just, we have folks come into PT all the time and utilize our facilities doing that. So without a problem. So I think once, they're taught exactly how to do it, and have a few practice runs, it certainly is helpful. And even PT, if someone comes in and does visits the restroom, it honestly changes the way their spasticity is as well. So a full bladder can really increase spasticity and make exercising movement just a lot harder. So a lot of our folks will come in, empty their bladder, come back out. for their session, and it's usually much more beneficial than working with a full bladder. So.
Excellent.
And I think it's important to let people know that's a way to take control back. You don't want a bladder that controls your every move and every plan and everything you do. And catheterization is a way to control that and, not let it control you. So.
Yeah, I think that's a great point about taking control, and it really is a tool to help you. So I think we have time for one more question, and then if we don't get to your question right now, I'll tell you a way you can submit a question to Can Do MS. But Lindie, we have one viewer that has tried pelvic floor training, didn't work, so they've tried manual intervention, but they're looking for some other strategies. So would you maybe recommend giving pelvic floor training another chance, or is there what would you recommend as sort of the next step of that they're trying to get away from manual intervention, but so far pelvic floor hasn't been working?
Has not worked. I would want to dig in a little bit deeper to see exactly what their pelvic floor rehab entailed. That would be where I would start. If I didn't hear them saying those big key words that you would hear in pelvic floor rehab, like, Kegels and biofeedback and just kind of those tips and tricks with a specialist, I would want them to search out for another specialist. However, if that was not the case and they were with a specialist and it didn't work for them, then I would send them back to neurology, who can decide if seeing another physician would be beneficial, urology, just to see if maybe a different medication would be a better route, or sorting through those kind of layers. So if there wasn't a specialist involved, revisit a specialist. If so, and we gave it the good college try, go back to neurology. Neurology can decide the best route from there, whether they can take care of it in-house or if they need to refer on to urology.
Tracy, anything to add on that before we wrap things up this evening?
I would just reinforce what Lindie said and realize that as a provider, we want to try, first of all, the thing that offers you the most benefit with the least harm. And so pelvic floor muscle therapy is definitely, exercise is medicine, and it's the best medicine. Now, sometimes you need to move up the scale of things and go to something else. So definitely, if it didn't work for you, then go back and see what the next step is. And don't assume, well, they can't help me because that didn't help.
Right.
That's a lot of folks will give up after the first intervention. So.
Yeah. Great. Well, thank you. I know we're going into overtime yet, but I think it was important to hear those problem-solving steps. And if something isn't working, there's always something else out there to try. So I appreciate you walking us through that. And thank you, Lindie and Tracy, so much for your time and for sharing your thoughts on this really important topic that I don't think gets talked about enough.